And I would like to thank all the youngsters, new budding cataract refractive surgeon, to be here and to give us a chance to be with you. And it's wonderful to see you all here. So the topic which Rohan gave me was that making niche in keratoconus, how does it help all of us? So I assume I'm talking to a young budding group of surgeons, and I'm going to keep it like that, and I'm going to convince you that why should you think about treating keratoconus. Now, the first thing which arises when I'm talking to a refractive surgeon would be, well, keratoconus is biggest nemesis of a refractive surgeon. Something which you have to learn is to actually find out keratoconus and rule it out. Now, this is what we are taught. But why just rule it out? Why can't we treat it too? And that's not difficult. And why does it need to be treated? Well, if you look at the prevalence, what Jose Jonas had published from Indian scenario, they found that the prevalence was 2.4%. And if you multiply by 136 crore people in India, that means potentially we have almost more than 3 crore keratoconus patients around, and they're going to just increase by future because of urbanization, allergy, and better diagnostics. So this is a potential which you do not want to miss out on. Now, this is exactly how I would like to treat my keratoconus patient. Based on, I classify whether the cone is centered or cone is decentered or cone is very advanced. Now, very advanced we'll talk about later on. If the cone is centered and if it's stable, of course, you don't need to stabilize it, and you just need to do visual rehabilitation. If cone is progressive and centered, we need to do a collagen cross-linking and stabilize it, and then do a visual rehabilitation using whatever devices you have. If the cone is decentered and if it's stable, visual rehabilitation, possibly using either INTACS or contact lens. If the cone is decentered and progressive, of course, it has to be combined with a cross-linking and make the cornea a little regular by using either intracorneal ring or topo-guided PRK. And finally, we can think of a visual rehabilitation. So this is just for the gross understanding. We'll come to each of them one by one. So central cone, when the cone is within 3 millimeter zone of the cornea, and if it's not stable, we have to do collagen cross-linking. 2003, it was Theo Seiler's group who published first time a technique which was so simple, where using an ultraviolet source of light, we could actually strengthen the cornea, and which was very simple. Earlier, it started with conventional, and now most of us follow the accelerated protocol. Is it worth trying it out? Of course, it's the technique is so simple and technique is so rewarding that it's certainly worth trying out for anybody who has interest in keratoconus. Now, all these techniques, I have just deconstructed them in certain headings for you to understand. That's effectiveness of treatment, technical complexity, other usage, and value for money. So if I evaluate collagen cross-linking for you in this way, well, it's very effective and it's mainstay of treatment. So, of course, it's very effective treatment. Technically, it's very simple. It can be done by an assistant too. So, technically, it's not very difficult. You don't need to learn a great amount of things there. Other usage, well, if you're a refractive surgeon, it may be useful for PRK extra, LASIK extra, SMILE extra. And with the cost involved, it's certainly value for money. So, as a young budding refractive surgeon, I would say go ahead and do the surgery. However, please remember, the collagen cross-linking is only meant to stabilize the keratoconus, and it's not for the visual rehabilitation. And for the visual rehabilitation purpose, we need to do other techniques and we need to utilize other things, which will come one by one. So aim of the cross-linking is to stabilize the cone and not the visual rehabilitation. So let's see if the cone is centered and it has a low spherical equivalent, refractive error is not very high. Well, we can do something called intracorneal ring implants or INTACS. I have experience with INTACS only, so hence I would stick to just INTACS. These are the PMMS segments which we place on the in the periphery of the cornea, which flattens the cornea, and hence it reduces the conicity, it improves the quality of vision, and more importantly, it helps you in part visual rehabilitation. The technique is not very difficult. With the femtosecond laser, it becomes very, very easy. And somebody who has femtosecond laser, all you need to do is just make a channel and insert ring according to your plan. When you can see on the right side, with the rings in place, the cone flattens down, it reduces, If the cone is a little decentered, it may actually become a little more centered, and it can certainly help you to improve the quality of vision. Does it mean that these patients would not need any glasses, contact lens? I would say certainly not. So if I again deconstruct the same thing based on the effectiveness of treatment, well, it's effective. It's going to flatten the cornea, but unfortunately, it's not a predictable outcome treatment. So you cannot always say that it's going to give you a predictable refractive outcome. Technically, it's pretty simple for any refractive surgeon, any cataract surgeon can safely do it. But sometimes the planning can be a little tricky, and it's not difficult to learn that. Unfortunately, it does not have any other usage, so it has to be for keratoconus and post-LASIK ectasia. Value for money? Well, I would say it can be value for money provided you have the femtosecond laser. So if you have femtosecond laser, go ahead and do the treatment after understanding what you are aiming at, what you're going to get from that. Now, if you have high spherical equivalent, cone is centered, and if you have already cross-linked the cornea, which we saw earlier, then we can use phakic intraocular lenses or phakic IOLs. We have ICL, IPCL in our hand, and it can be of certainly great importance, especially the cone is centered. If the cone is centered, as you can see from this example, significant high myopia with high cylinder, but good anterior chamber depth, well, the patient had undergone INTACS, and in such kind of cases, whether to reduce the spherical error or to take care of the entire refractive error, you can actually use a phakic intraocular lens. Remember, not all these cases can undergo phakic intraocular lens, because with the phakic intraocular lens, we are only going to take care of sphere and cylinder. Anything which is higher order aberrations like coma, which you can get in keratoconus, cannot be treated by this thing, and patient can have significant amount of ghosting. So remember to select your case appropriately, and which can certainly give you a very good outcome. The technique is very simple, and as you can see from here, you can get gratifying result. But as you can see from here, the patient can have little amount of ghosting, which may not be disturbing to some, but which can be sometimes disturbing to others. So again, evaluating the technique by the same thing which we saw. Is it effective? Well, it's effective in central cone, but that means there are certain cases which can be treated with phakic IOL, and not every keratoconus cases. Is it simple? Of course, it's pretty simple, and it can be done by any cataract and refractive surgeon. The technique phakic IOL primarily can be used for myopia, hyperopia. So if you know the technique well, you have other cases to treat also. Value for money? Well, it does not require any special instrument. So certainly it's a value for money. So yes, go ahead and use it in selected cases in phakic IOL. If the person is little senior age group and has a stable cornea and the cone is centered, well, you can actually use toric intraocular lenses also. As you can see from this example, a high myopia with keratoconus and had a significant amount of axial myopia and axial length of 32 millimeter, went ahead and did a custom toric lens here, where the power was minus 12.5 and the cylinder was 4.5. As you can see from here, the result can be quite gratifying. A simple thing like a cataract surgery, and with your knowledge of toric IOL, you can actually visually rehabilitate them. So effectiveness wise, well, there are certain cases which can work. Not all the cases of keratoconus can be treated. Technically, it's not as difficult for cataract surgeon who are used to toric IOL, but these are complex cases, so be careful about that. It's a technique which you're using for your normal cataract surgery, so of course it's useful and it's certainly value for money. So yes, I would approve that toric IOL for keratoconus you can use. And again, you look at this thing, you're expanding your horizon, just being a cataract and refractive surgeon, and you can safely treat keratoconus. Now we come to a decentered cone. The cone is not centered, as you can see from the pentacam here. And if you have decent corneal thickness, well, you can connect your laser machine, your abrometer or topographer with that. And if your laser machine allows you, then you can do a topo guided or wavefront guided PRK, reduce the irregularity of the surface, reduce the conicity, and make the surface a little more regular. As you can see from here, a decentered cone becomes more of a nice regular astigmatism, which can be treated very easily with glasses. So certainly gratifying outcomes in selected cases. So would you suggest to undergo, I mean, would you undertake this kind of technique for the keratoconus? Of course, I would say very effective, technically quite simple if you know how to do a topo-guided PRK, and certainly value for money if you already have a LASIK machine which can give you a topo-guided treatment. Finally, if it's in very advanced cone, you try to see whether you can fit a contact lens or not. If your contact lens can be fitted, you can think of a cross-linking which can be done with a thinner cornea, and then finally visually rehabilitate with the contact lens. If they are not fitting, you can think of doing a dark. Now, as you can see, one of the case which had come to me and was advised cross-linking till I saw the corneal thickness on ASOCT that it was very, very thin cornea, 200 micron only. And we went ahead with contact lens trial there. And with the contact lens, patient vision was almost 6 parts. Patient refused to undergo any surgery, and patient was very happy. And we could visually rehabilitate that. So specialized contact lens for keratoconus is certainly worth learning. You need somebody who can spend more time. So technically complex, well, I would say you need to learn the subject a little bit. Otherwise, it's certainly value for money, and it can be used for any of your normal cases. Finally, if the cone is very advanced and you can't do anything, then ultimately you end up doing a lamellar keratoplasty. Lamellar keratoplasty here, I'm doing a femto-assisted lamellar keratoplasty, a mushroom graft. And lamellar keratoplasty, as Dr. Rajesh Fogla was showing, that it can be certainly a good technique to give a long-term outcome for the patient, and if done properly, can do wonders. However, in the hands of a non-cornea surgeon, it can have little longer learning curve. For cornea surgeon also, you need some good teachers like Dr. Fogla and Vikas, and they can certainly teach you the nuances of surgery. Done properly, the surgery can certainly do wonders for the visual rehabilitation purpose in the patient. So if I finally conclude that the effectiveness of treatment is tremendous in selected cases, technically it is challenging and it's not a cup of tea for everybody. So a part-time cornea surgeon or somebody who has not learned cornea, who has not learned these lamellar technique can find it difficult. But having said that, there are a lot of surgeons who have learned without learning the entire cornea these lamellar keratoplasty, and they do really well. So overall, if you are aspiring cornea surgeon, you surely can do this technique. Finally, before I close down, again showing the same flow chart, divide the cone center, decentered, based on progressive, non-progressive, and finally the visual rehabilitation is most important. Thank you very much.
Thank you so much, sir. Dr. Gaurav and Dr. Himanshu, sir, your comments on keratoconus and how to go about it as a young surgeon. Should you invest more time in actually finding out patients and then going ahead with treatment for keratoconus? Or if you are in a private practice, or if you are in a secondary center, always refer to a tertiary center. What's your take?
Not at all. The primary thing is to pick it up early. Before the topography came, when we were doing our residency, the only way out for keratoconus was a cornea transplant. Things have changed tremendously. You don't even know that, till 2005, we did not have the C3 CXL treatment also. So, we were still very rudimentary. You have such a beautiful treatment, so easy. It's as simple as doing a Collagen. You don't have to even think about it. So there's no reason why everybody should not be investing in a topography. Even a cataract surgeon should have a topographer at hand for them to find out the axis for their toric axes, for putting up whether you have what amount of delta you have your axis, your multifocals. When you're doing that, you pick up a K-conus, you will feel happy. And most often than not, it's missed out because a high astigmatism and the child rubbing their eyes. If you are picked up very early, you are going to avoid a lot of problems in the future. Absolutely no reason why every beginner should not be looking at keratoconus. It's something which you cannot afford to miss, period.
Yeah, I completely agree. In fact, Dr. Himanshu, because there are a number of instances where a parent will bring a child who has been seen by another ophthalmologist, followed up for over 3-4 years. You can make out that the child was going into a keratoconus, has signs of allergy. You can make out the astigmatism, the skew, and everything. And then the difficult question that why didn't my previous ophthalmologist detect this when you could? and then you have to, of course, defend them and say that sometimes in the early stages you would not. Now that should not happen to any of our youngsters today. When we were kind of going through our stages, keratoconus was not so easy to detect, because all we could, which still holds good today, scissoring on retinoscopy was the mainstay, and looking at the cornea and other things, which still holds very, very true. When in doubt, I think scissoring is one big thing. But of course, as you said, I think today youngsters should really be focused. It's something which you can easily diagnose, and if you miss it, it could be actually it's like very embarrassing if you've actually missed a keratoconus and somebody else later diagnoses it. So it's definitely worthwhile investing in time and looking for these patients, and you will invariably find them. And then as you said, investing in a topographer is not difficult, even if it's a second-hand one. I'm sure very many people who's upgrade to a pentacam or something else will be happy to send off one of their old topographers. Definitely do that. And as a cataract surgeon, you need one too, anyways, if you're doing toric also. And then, of course, treating it. But here, a word of caution. I do see, some overzealous, attempts at cross-linking, which can then land you in soup, especially eyes which are 6'6", 6'9", and some people would advise cross-linking on the first go. I tend to follow up patients for a few months, a year, sometimes 2 years. So many of them actually regress without treatment if you've just concentrated on avoiding eye rubbing. So let's not be trigger happy when advising cross-linking. Let's do it the right way. The case selection, follow-ups, and also the technique. And sometimes machines are not calibrated. They may have wrong energies. We may end up using wrong dyes. So while it's a straightforward treatment, but the scope of complications is there, which is totally avoidable. So I think that do what you are comfortable with. Don't try to overdo things as well, and refer when you think that it's the right time to refer as well. So this would be my take-home message for the youngsters, at least.